हेलो माय डियर स्टूडेंट्स, ए वेरी गुड इवनिंग टू ऑल ऑफ यू गाइस। सभी लोगों को खमंगनी नमस्कार और सभी लोगों को मेरा सलाम। आई एम डॉक्टर अरुण स्वामी अगेन योर फिजियोलॉजी फैकल्टी बेटा। सो ए वेरी वेरी गुड इवनिंग टू ऑल ऑफ यू गाइस। कैसे हैं आप सब लोग? Yes, so preparation, I hope that everybody preparation is going on the full swing, and today as also you got your examination center email on your registered email ID that's you have been done during your application form filling time. So I hope that everybody got their mail and now already you know that where is your test center, right? So yes, Bida, yes, Atul, Tariq, Sam, yes, everybody, Srinivas, everybody. Yes, beta, Jaya, Babu Rao, everybody. Yes, beta. Very, very good evening to all of you guys. That's again बेटा बहुत अच्छा लग रहा है आज काफी दिनों बाद आप सब लोगों से दोबारा से एक बारी मुलाकात करके, क्योंकि that's you know already that there was a 1 month has been finished after finishing your classes. So again we are meeting again on this live YouTube session on Miss channel. So I hope that now everybody prepared with the full of their dedication, full of the hard work. But guys, now this is the time when you have to play very smart. First of all, don't be stressed. Don't think that you have studied a lot and now you don't remember anything. ये नहीं घबराना है. Because whatever you studied brother, in this time, everything you are having in your subconscious mind. Once you will see the MCQ on the screen of the computer, immediately you will get the answer of this MCQ. So don't think कि आपको सब कुछ भूल गए हैं सर, अब हमारे को कुछ भी याद नहीं आ रहा है सर, हम कैसे करें, क्या करें, और सर अब डर सा लगने लग रहा है बेटा. Actually, this fear, this stress, this is actually need to be checked out in this examination. This examination is not checking out only your knowledge. This is checking out your handling process, means how you can handle to anybody when even you are in stress condition, when you are in fear condition. So this is how all of this examination is actually check all this ability into the individuals. So that's why guys, बस बेटा लगे रहो, पढ़ते रहो और 100% अपना देते रहो बेटा. The 12th of January will be yours day and that will be the your time, and 100% you are going to crack this exam at any cost. So with this thought of mind, we are here to study 25 most important physiology clinical questions from the missed 25 important series, and now today we are going to discuss all of these important topics. Guys, actually this PDF or these questions are actually made something like that, means during that's previous some examination, all of these questions or all of these topics were the high yield topics. So actually I tried my best to give you all of these questions in a very short manner so that you can easily memorize all of these part, and hopefully those questions are going to be help you a lot on the 12th of January your FMG exam. So let's start this 25 most important physiology clinical question series, right beta? So are you ready? Yes, come on. So now there will be the first question on your screen and this is your question. Yes guys, so the first question on your screen, that which of the following best describe the role of calcium in the muscle contraction? Yes guys, so the options are: number one option, calcium binds to actin, enabling cross bridge formation. Number two is calcium binds to troponin, leading to exposure of the myosin binding sites on the actin. Number three, that is calcium binds to tropomyosin, blocking the active sites on the actin. And option number D is calcium directly binds to the myosin, causing it to change the shape. Yes, guys. Yes, please answer. Everybody, please start answering. Yes, guys. Yes. Yes. Everybody. Very good, guys. Yes. So many of you answered correctly, guys. So see, that's the physiology जो आप कहते थे बेटा कि आप लोगों को पढ़ना इसको मुश्किल नहीं नामुमकिन है, Now, I hope that this physiology is very, very easy from your side and you are having full of confidence कि yes sir, it's B, पक्का ये B है. And yes beta, those who answered correctly the B, yes, the right answer of this question is B. That is, your calcium binds to the troponin, leading to the exposure of myosin binding sites on actin. So yes, option number B, that is your correct answer. So guys, if you remember how the calcium is required for the muscle contraction, so I hope you know that this is your muscle myocyte. This is your muscle myocyte. Yes, guys, we studied this diagram in the class and we know that this is your sarcoplasmic reticulum, and this is containing a receptor over here, and this receptor we called as a ryanodine receptor, right? Another receptor which is present over here, and this receptor is present on this area, and this receptor is actually we called as DHPR. Remember guys, DHPR, and this DHPR stands for dihydropyridine receptor. This is your T-tubules, and this is your L-tubules. This is sarcoplasmic endoplasmic reticulum, which is actually the warehouse of the calcium. So all the calcium is situated inside of this sarcoplasmic endoplasmic reticulum. Here it is your sarcomere. This is your sarcomere, and in this sarcomere, two proteins are there, actin and myosin. So we know that first of all, action potential will come. First of all, the action potential will come from here. This action potential will go inside, will activate the DHPR. This DHPR will activate the ryanodine, and this ryanodine will open up, and now this calcium start moving outside. This calcium will go over here, and this calcium binds with the another proteins presents over here, and this supporting proteins we named as a troponin, which containing the three binding site trop T, trop I, and trop C. Guys, you know that this trop I, that is for the actin binding site, trop T for the tropomyosin, and this calcium will bind at the trop C area. Once it will bind to the trop C, what will be happen? The tropomyosin will be go away. Now this actin area is free for the myosin, and myosin head will come and it will fix into the actin. Using of the ATP, it will do the muscle contraction. So absolutely, you know that's right answer of this question is the calcium binds to the troponin, leading to exposure of myosin binding sites on the actin. So everybody who answered B, that is absolutely right and correct, right beta? Now coming to the second question. The second question is that which of the following is the correct sequence of event in the muscle contraction? Yes guys. So as I already described this explanation in the previous question, so now you have to answer for this part. What is the correct sequence of the event in the muscle contraction? Please arrange all the orders and identify that which is the correct sequence of event in the muscle contraction. Yes beta. Yes, yes Atul, calcium बाहर आके trop C से चिपक जाए, right? So many of you now you could understand that calcium is not only for the bones, right? Calcium is actually is required for the muscle contraction. Very good, Bada. Very well done. Yes. So which of the following correct sequence of events in the muscle contraction? Yes. Yes, dear. Wonderful. Wonderful, wonderful. Right, Peda. So you know that's just now we have been talked about that first of all, what will be happen? The first of all, this action potential will come. First of all, this action potential come. It means this is coming with the phase of depolarization, right? Depolarization. क्योंकि जब भी current आता है बेटा, this current is actually formed from the depolarization, then the action potential form, then again the repolarization is going to be happen. So this is the depolarization. Which ion moves inside during the depolarization? Yes guys, to making inside cell positivity, which ion moves from outside to inside for making the depolarization? Please answer me on the chat box. which ion should go inside to the cell membrane? Yes, yes, to doing the depolarization. Yes, guys, please answer for this part. Which ion will move inside to the cell membrane to doing the depolarization? Yes, yes, Akshat, it is sodium. So this will leading to what, beta? Sodium influx. So depolarization is actually happens mainly due to sodium influx, and it is sometimes helps via the calcium influx, right? For repolarization, for repolarization, for the repolarization, which ion will move outside? The repolarization mainly is occurs via potassium efflux, right, brother? It is mainly done via potassium efflux. So here you can understand easily what is the role of this sodium and potassium and the calcium, and how this repolarization is going to be occur. So now please answer for this part. Which is the correct sequence of events in the muscle contraction? The number one event, that is, first of all, what happening? The depolarization is going to be happen. The depolarization you can see over here. So first of all, there is what is going to be happen? There is the depolarization is going to be happen. This depolarization will activate the DHPR, will activate the ryanodine, calcium efflux will be there, binds to the troponin C, and so that there will be the myosin head will bind with the actin. So cross bridge formation will be happen. Using of the ATP, muscle will be contract. So here you can see that option number A. What option number A is saying? That first of all, depolarization, calcium will be released, cross bridge formation, ATP hydrolysis, and the contraction. Absolutely, this is the correct. This is the true. Let's talk about the option number B. ATP hydrolysis, calcium release, depolarization. No, beta. This is wrong statement. Then calcium release, no. Cross bridge formation, no, beta. For forming the cross bridge, you require the calcium, and for calcium, you require the depolarization. So again, this is the wrong statement. Option number D, repolarization, calcium release, that is again a wrong option. So this right answer of this question is option number A, that is depolarization and the calcium release and the cross bridge formation, KTP hydrolysis, and the muscle contraction, right? Muscle contraction. For doing the muscle relaxation, guys, you know which pump is required? The Sarka pump is required. What the Sarka pump will do? The Sarka pump will throw back this remaining calcium into the sarcoplasmic endoplasmic reticulum, and that is Sarka pump stands for sarcoplasmic endoplasmic reticulum calcium ATPase pump, right, brother? Yes. Now, yes, Atul, you are asking that, sir, Nokia. Guys, first of all, many students gets confused over here. Guys, suppose this is the cell membrane. This is the cell membrane. Initially, sodium is present outside, potassium is present inside. Guys, we know that if inside area is negative, if we want to make it positive, first of all, which ion should move inside? The sodium will move inside. So initially sodium will moving inside. So this is happening without any energy. No ATP is required. No ATP is required at the moment, and sodium will move inside. Later on, this potassium will move outside, and again no ATP will be required. But now, as this interchange is done and forming the action potential, now for again sending this ions to their normal positioning is required. इनको वापस अपनी जगह पर भेजना पड़ेगा, and now when you are sending back these ions back into their normal positioning and the normal area, now you require the pump, and this pump stands for sodium potassium ATPase pump, right, guys? Sodium potassium ATPase pump. And now this pump will do what? This pump will do, that's Nokia. What this pump will do? This pump will do the Nokia, that's the mnemonic, and Nokia stands for sodium out, potassium in, via using of ATP, right? So this pump when activate, then what will be happen, guys? This sodium will again move out, and this potassium will again move in. This is the function of this sodium potassium ATPase pump, and the coupling ratio of the sodium potassium ATPase pump, that is your 3:2. What is the coupling ratio? 3:2. So how many sodium will move outside? 3 sodium will move outside, efflux, and 2 potassium will move inside. So this will happening the influx. So this is how you should be remember. Don't be confused that sir that sodium is moving outside. No, initially sodium will move inside and potassium will move outside. But now after this process is done, sending back this ion is required. So now this sodium will move outside and potassium will go back inside. Thus required the energy. That's why we are using the pump called as sodium potassium ATPase pump. Right, brother? Now the next question. Question number 3. The question number 3 is which of the following is a direct result of acetylcholine binding to its receptor on the muscle cell? Yes, guys, please answer for this question. Which of the following is a direct result of acetylcholine binding to its receptor on the muscle cell? Option number A, the calcium released from the sarcoplasmic reticulum, activation of myosin heads, contraction of the muscle, and sodium influx into the muscle cell leading to depolarization. Yes, guys. So please answer for this part. Yes. What will be happen? Think about it and then answer. Yes. Yes, guys. Please answer for this question. Yes. Oh, yes. So many of you are answering D, some of the answering A, few are answering the C. And now I am making this diagram. Again, once you will see this diagram, immediately you will get your answer and you will start answering me correctly. Right, Bida? So please pay attention. Guys, we talked about this is, suppose this is your axon and this is the terminal axon. Right, Bida? This is axon and terminal axon area. This is your muscle area like this, right? And I told you this is your synapse. Now what is happening initially? Initially there is action potential will come, calcium will be in flux, this will release the acetylcholine from here, it will do getting out via this presynaptic area, and this process we called as exocytosis. This acetylcholine will rush over here. This will bind with the receptor. So this acetylcholine bind with the receptor at the postsynaptic area. And now this will give the message to the nucleus. And what this nucleus will do? This nucleus will open the channel for the sodium. So this is opening the channel for the sodium. So sodium will start moving inside. This will start moving inside, and this can changing the negativity into the positivity, and this is how this will go to the motor unit, and this is how the DHPR is going to be activate and muscle will going to be contract. So now you know that's what is the all are the events going happening over here. So here you can see the question is asking what will be happening when the acetylcholine binding to its receptor on the muscle cell. So it means this acetylcholine when binding to the muscle cell receptor, what is happening? This is ultimately opening the sodium channel. So this is the right answer. Right answer of this question is sodium influx into the muscle cell leading to depolarization. So right answer of this question is option number D. Right, beta? Now, calcium released from the sarcoplasmic reticulum. Guys, this is not directly over here. This is happening when this action potential will reach to the DHPR, then to the ryanodine receptor, and then it will go into the sarcoplasmic reticulum. Activation of myosin heads, it is not directly happening with the acetylcholine. It is happening due to the calcium binding at the troponin C. Contraction of the muscle, it is not happening via this process. This is having all this complete chain. So right answer of this question is sodium influx into the muscle cell leading to depolarization. Guys, why I given these three questions back to back like the same questions? Because this is going to be very important part, and now they will not directly ask to you this questions from this area, they are actually checking your knowledge whether you are having all these steps correctly or you are not aware about this part. So this is very, very important part which you should know. That's all of this area, right, beta? Now please pay attention, as this is the synapse area. One more thing we are going to repeat over here. Now this is the area where few things we have been discussed, few pathological condition we have been discussed. The number one condition which we have been discussed over here, this condition was when suppose if this calcium is not able to move inside properly, this fast calcium channel is going to be defected. Guys, please answer me, which condition? If suppose this fast calcium channel is going to be defect, this calcium is not able to enter fastly inside this area into the presynaptic area, what will be happen, guys? What is that condition? What is that condition? Yes, please answer. Yes, no, no, Majud. This is not myasthenia gravis. Remember, guys, this is Lambert-Eaton syndrome. This is Lambert-Eaton syndrome. Remember? Yes. So this is if the fast calcium channel is going to be defected at the presynaptic area, that's we called as Lambert-Eaton syndrome. It contain a protein over here, this acetylcholine. This protein we called as snare protein. This we call as snare protein. If this snare protein is going to be defect, this defect done via which condition? Botulism toxin. Botulism toxin. So botulism toxin destroy this snare protein. So what will be happen? If the snare protein is going to be defect, this acetylcholine vesicle is not going to be attached this presynaptic membrane. No exocytosis will be happen. No receptor binding will be happen. No activation of this channel. So this is how the botulism toxin can cause the paralysis of the muscle. Right now, the next event is if suppose this postsynaptic receptor of myasthenia is postsynaptic receptor of this acetylcholine is gone. If this receptor is gone, what will be happen, guys? No acetylcholine could be bind to this area. If no binding with the receptor, no message will go inside the cell. Hence, no activation again for this sodium channel. This condition we called as myasthenia gravis. Myasthenia gravis. Myasthenia gravis. So you can see that myasthenia gravis is the condition for postsynaptic area, but the Lambert-Eaton syndrome is the condition of presynaptic area. So please remember, guys, all of this condition. You should remember all of this pathological condition. One of the question might be you will get in your exam from this pathological side. If this myasthenia gravis is happening over here, what could be the treatment for this part? Guys, the receptor is the job and duty of the nucleus. You can't give the message to the nucleus that please produce the new receptor, क्योंकि आपका वहां पे रिसेप्टर खराब हो गया है. और अगर आपका वहां रिसेप्टर खराब हो गया है बेटा, आपको बस वहां रिसेप्टर चाहिए. If you want to solve this condition, you just require the receptor, but receptor is actually forms with the command of the nucleus. So now none of the drug in the market which is available which can give the signal to the nucleus that please produce the new receptor. So what is the treatment? Treatment from your side as a doctor, what you can do, you know that whenever the acetylcholine comes into this area, that unused acetylcholine need to be get off from this area, and this job is actually done via acetylcholine esterase enzyme. So this job is done via acetylcholine esterase enzyme, and this enzyme will not allow to be function via blocking a drug called as neostigmine, physiostigmine. So yes, this pyridostigmine and the neostigmine. So this is how this acetylcholine esterase is not going to be function, and now we are allowed to stay this acetylcholine at the postsynaptic area, so that if any new receptor is formed, this acetylcholine can immediately bind with that part, and this message can go to the nucleus, and so that functionality could be occurs, right beta? So this is how this area is actually functions, and I hope now you can easily remember. तो बेटा आपको ये पूरा NMJ याद हो गया. NMJ is very, 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 very important for your 12th of January exam. You need to be remember this part. So all of this event we have been discussed in this session. Now coming to the next question, the absolute refractive period corresponds to. Yes, guys, the absolute refractive period corresponds to. Yes, yes. Please answer. Yes, beta. So, absolute refractive period. First of all, tell me what is the refractive period? What is the refractive period? Refractive period means the time when the one action potential is going on. Remember, guys, this is the graph which we have been discussed. If the one action potential is going on, this is suppose your threshold value, and if one action potential is going on, then the repolarization like this. So you can see over here, if the one action potential is going on, this is the depolarization area, this is the repolarization area, and this is the action potential area, this is hyperpolarization area. So now you can see over here, if the one action potential is already going on and it is coming back downside like this, during this time, if you will give any other stimulus to the muscle won't show any response. It won't show any response, right? So this is how, if the one action potential is already on the way and if giving the new stimulus muscle won't show any response, that we call as refractive period. यानी कि अगर आपको एक काम मैं ऑलरेडी दे दूं and in between अगर मैं आपको दूसरा काम बोलूं, तो guys what you will say me, you will say me कि sir let us finish the first function, the first work, then only will start for the second job. So this is how this muscle is also like this. जब एक एक्शन पोटेंशियल इज ऑलरेडी ऑन द वे, another stimulus will not give any functionality for this area, or this muscle won't show any response for this stimulus, that we call as refractive period. That can be divided into two types: absolute refractive period and the relative refractive period, right beta? So this is the complete refractive period from this area. This is the complete refractive period from this area to this area. This is the complete refractive period. Complete refractive period. But if we'll talk about over here, then from this area up to this area. So what is this area? This area is actually your complete depolarization and the 1/3 repolarization. This area we called as absolute refractive period phase. And from this area up to this area, from this area up to this area, this we called as relative refractive period. What does it mean, guys? It means that if you give any type of stimulus over here, doesn't matter what type of strength is there, if you give any stimulus over here, muscle won't show any response, called as absolute refractive period. But if you will give the stimulus at this stage via giving little bit more strength of this stimulus, this muscle again will go into the functionality or the depolarization or the contraction phase, and then again it will come like this. So that is why we call this relative refractive period phase, absolute refractive period phase. And this is how the question is asking that absolute refractive period is corresponds to. The absolute refractive period is corresponds to option number A, the time when no stimulus can initiate a new action potential. The time when stronger than the normal stimulus can initiate a new action potential. No, this is again the wrong options, because this is for the relative refractive period phase we are talking about. But here the question is asking about the absolute refractive period. Option number C, the time when sodium channels are open and the potassium channel are closed. Guys, in this area we know the sodium channels are open, but here the potassium channels are open, right? So here you can see that this is not completely the potassium channel are closed, right? Now the time when the sodium channels are inactivated and the potassium channels are open, right beta? So this is how, this is again, you can't say that sodium channels are inactivated. No, this is not the inactivated. During this time the sodium channels are activated and the potassium channels are also open, and this opening up to this area only. So what is the right answer of this question? The right answer of this question is option number A, the time when no stimulus can initiate a new action potential. Right, beta? New action potential. Okay. So this is how the right answer of this question is A. Coming to the next question, the which ion can move independently? Which ion can move independently during the resting potential of the cell membrane? Yes, guys. Which ion can move independently during resting potential of cell membrane? Yes. Yes, guys. Please tell me what is the right answer of this question? Sodium, potassium, both, or the potassium? Yes. Which ion can move independently during resting potential of cell membrane? Very good, guys. Very good. Wonderful. Wonderful. Everybody. क्या बात है बेटा, छा गए आप लोग. Superb. So everybody answered very well. Yes, it is your potassium ion. So it is the potassium ion, guys. Remember in the class, we discussed a lot of times that only the potassium ion which can move freely in and out during the resting condition of the cell membrane. During the resting time, the cell membrane is nil permeable for which two ions? Sodium and the calcium. But it is fully permeable for which ion? The potassium. तो पोटेशियम तो घर का बच्चा है, पोटेशियम तो सेल का बच्चा है. तो बच्चा जब अपना खुद का है तो वो बच्चा घर के अंदर भी रह सकता है, घर के बाहर भी रह सकता है, जब कोई सारे लोग घर के सो रहे हैं. बट जब सारे लोग घर के सो रहे हैं, उस समय बाहर का कोई भी बच्चा घर के अंदर नहीं आ सकता है. राइट. सो दिस इज हाउ दैट्स वी हैव बीन डिस्कस इन द क्लास दैट हु इज द घर का बच्चा, हु इज द सेल का बच्चा. सेल का बच्चा इज योर पोटेशियम. राइट. सेल का बच्चा इज योर पोटेशियम. राइट बेटा. यस यस अतुल. यस यस यस. वेरी गुड. सो दिस इज हाउ गाइस. देखो आप लोग तो कहते हो कि सर हम तो भूल गए सारी चीजें, हमको तो कुछ याद ही नहीं है. Guys, you are not forgetting anything. You are able to remember to everything in your subconscious mind. Once you will see the question, immediately you will get your answer. तो बेटा बस अब आएगा आपको असली मजा. That's you will immediately get your answer on the 12th of January when you will see the question on the screen, right? So just believe in your boss. Believe in your boss. Boss is always with you and boss will never let you down. Okay, so I hope you can remember easily all the things during the examination time as well. Just what you need to do, you just need to believe in yourself that yes, you can do it, and you are 100% going to do it, guys. 100%. I believe on you. All the Miss family believe on you that you can crack it, and you are going to rock on the 12th of January, and you are coming with your flying colors. हाँ बच्चा जी. Yes, right. The next question is, a 25-year-old male presents in emergency room. ER means emergency room with RT history. During examination, he found hypotensive, tachycardic with palpable abdominal mass. His E fast positive. He went under emergency surgical procedure and done jejunectomy. Identify which substance deficiency can be seen in this patient. Yes, guys. Yes. Yes, dear. Please tell me. Calcium iron, vitamin B12, or the amino acid? Yes. Yes, guys. So now, doctors, now see, you can able to understand this such type of questions. Remember, the day when you first time came to the India and you started your preparation for this FMG exam, guys. How all the simple question even was very difficult for you, but now with your hard work, with your dedication, and with your knowledge, all such questions are like a गुलाब जामुन टू ऑल ऑफ यू गाइस. गुलाब जामुन को क्या करना होता है बेटा? बस उठाना होता है और मुंह में डाल के अंदर ले जाना होता है. राइट. सो दिस इज हाउ इट्स इजी टू ईट द गुलाब जामुन. द सिंपल वे answering of this such questions are very easy, right guys? Very good, guys. Very good. Well done, guys. The right answer of this question is vitamin B12, vitamin B12, right? So we know that during the classes we have been studied that suppose this is your stomach, this is your stomach, this is your duodenum, then this is your jejunum, and suppose this is your ileum, and then this is cecum, and then your large intestine will be started. So guys, you remember that I told you, talking about the absorption in this duodenum, the two things are maximum absorbs, that is your iron and your calcium. The two things in the duodenum, iron and calcium. All the maximum things in your jejunum, all the maximum things in your jejunum, and in the in the sorry beta, yes, please pay attention. Sorry, first of all go with this part. Yes, so this is maximum jejunum, and then this is your ileum, right? Ileum. In this area, vitamin B12. In this area, vitamin B12 and what else? Bile salts. Bile salts, right? Vitamin B12 and bile salts, right? Now, yes. And in this area, vitamin B9 as well. In this area, vitamin B9 as well. Yes, guys. So this is duodenum. Yes, everybody is right. Duodenum, jejunum, and the ileum. Right, beta? So this is the area. So now you can easily remember, in the duodenum, iron and calcium, jejunum, all other things like the amino acid, that's vitamin B9. In the ileum, there is vitamin B12 and the bile salts. Right, beta? Now, this vitamin B12, this absorption happens with the help of which factor? The intrinsic factor, the intrinsic factor the intrinsic factor, which actually comes from which area? Which comes from the stomach area. So this stomach area gives the secretion of this intrinsic factor, and this intrinsic factor helps for absorption for the vitamin B12, right? Now, so now you know all of this part. Now you can tell me the right answer of this question. Yes, guys. Yes. So he went under emergency surgical procedure. He done the jejunectomy, right? Beta, jejunectomy. Now identify which substance deficiency can be seen in this patient. Yes, yes. So you know that this area is gone. If this area is gone, which part is going to be a lack in this patient? Yes. Which part is going to be lack in this patient? Yes. We know calcium and iron. This is from the duodenum. Vitamin B12 from the ileum, terminal ileum, that is your, and this is from the jejunum. So right answer of this question is amino acid. Right answer of this question is amino acid. Right? So this is how you can remember this part. Coming to the next question. This is wrong answer over here. So just make it. This is option number D. Misprint this is. This is your amino acid. Now coming to the next. Yes. Coming to the next, identify which movement of the gastrointestinal tract is shown in the given image. Right, guys? So please answer, which movement of gastrointestinal tract is shown in the given image. So here you can see that what is the movement on this area. This is the area. Here you can see that's number one. Number one in the picture number A, that is the movement, the substance is present into this intestine. Then in the picture number B, this substance is breaks into the small particles, and in the picture number C, again it is going to the more smaller in the part. So what will be the right answer, guys? What will be the right answer? Peristalsis, segmentation, ostration, or migratory motor complex? Yes. Guys, see guys, That's how you are making the mistakes. This is not the peristalsis. This is not peristalsis, because what is happening in the peristalsis? In the peristalsis, that front side area, this back side area is going to be contract, but front side area should be relaxed. But here you can see what, that both the area front and the back area is contracting, and in between area is making a segment like this, and this segment is helping to break and mixing the food with the digestive enzyme. So this is not the peristalsis, this is segmentation. This is the segmentation. So actually this is the segmentation, right? So right answer of this question, that is actually the segmentation, not the peristalsis. Guys, in the peristalsis, what we can see, that in the peristalsis, suppose in the peristalsis, there should be like this. There's something should be like this. So the front side area should be relaxed. Front side area should be relaxed and the back side area should be contract. And here is the bolus. Here is the bolus. So this is how the peristalsis is going to be happen. This contraction is done via which two substance? Acetylcholine. Acetylcholine and substance P. So two substances required for contraction of this muscle, and for relaxation what you required? You required first of all the nitric oxide. First of all, you required mainly the nitric oxide. So this is how, and also what you require? VIP, vasoactive intestinal polypeptide. So two substance is helping for relaxing the area, and two substance is helping for contraction the area, that is acetylcholine and substance P, for relaxing the nitric oxide and the VIP. So that is the peristalsis, but here you can see in the both area, in this area that is the contraction, and in this area there is the contraction again. So guys, what is this? This is your what? This is your actually the segmentation, right? Segmentation. Now, in the hostration, this is like this. This is happening for taking out the some ions and the water from the undigested food, and the migratory motor complex, MMC. Guys, this MMC is actually motilin mediated, which is we also called as hunger pangs. जो अपन कहते थे कि पेट में चूहे कूद रहे हैं. So this is actually your migratory motor complex, and this migratory motor complex happens when you are in feeding state or fasting state. Yes, absolutely. When you are in fasting state. So fasting state, you need to be get off all this debridement from this area. So all this debris need to be get off from this area. So that is, we required a movement called as migratory motor complex, like the sweeper. Very good, like the sweeper. The next question is, which cell signaling shown in the given image? Yes, beta. Yes, dear. Which cell signaling shown in the given image? Yes. Which cell signaling shown in the given image? Juxtacrine, endocrine, autocrine, and the paracrine. Yes. In the cell signaling part, we have been covered this area. So what is the cell signaling of this? Yes. So few of you are saying B, few are saying D, few are saying C, but nobody said till now A. Okay. Okay. Fine. So let's see about this image. As we know, that's in the cell signaling type, we have been studied the different type of cell signaling, like the autocrine, contact signaling, and the paracrine, and the endocrine cell signaling. Guys, in the endocrine we have been studied that whenever this cell wants to give the signal to this area, this is required the blood for transferring this signal up to this cell. So any signal which is passing through the bloodstream, that's we called as endocrine cell signaling. But here you can see that this is the signaling cell, this is the signaling cell, and this is your target cell, and in between there is no blood stream is required. It means this is not the endocrine. So endocrine is completely ruled out. So this is not the endocrine. Now, coming to the next, that I told you about the autocrine. Autocrine means when the cell is targeting to itself only. अपन ने पढ़ा था कि जब अपना दिल टूटता है तो अपन किससे बात कर रहे थे? अपन खुद से ही खुद की बात कर रहे थे कि मैंने ऐसा क्या करा था कि मैं इतना पढ़ा था फिर भी पास नहीं हुआ, राइट? So this is how when the cell is targeting to itself only, we are called as autocrine. But here you can see this targeting cell is not this signaling cell is not giving to itself only the signal, so this is not the autocrine. So again, this is not the autocrine. Talking about the juxtacrine, guys, what is the meaning of juxta? The meaning of juxta means near. Near means two cells are actually nearby like this. Two cells are nearby like this, and then they are making the signal like this. This is the signal, you can call it also the contact signaling, right? Contact signaling by the gap junction. So again, you can see there is a clear gap between these two cells. So this is not the juxtacrine signaling. So again, this is not the right answer. What you can see, that this signaling cell is giving the signal to the nearby cell, and this nearby cell is, if gets the signal via the signaling cell without any bloodstream, that's we called as paracrine cell signaling. What we call this? Paracrine cell signaling. So right answer of this question is option number D, that is paracrine, right guys? So this is how I hope you can easily understand all of this different type of cell signaling. Now, coming to the next question. Yes. So which of the following describe the role of the glucose transporter in facilitated diffusion? So we have been discussed many times in the class about the GLUT and the SGLT. GLUT is different type, GLUT 1, 2, 3, 4, 5, and the SGLT is two type, that is SGLT 1 and 2. SGLT stands for sodium glucose link transporter, right? So this question is talking about the glucose transporter. So what is the glucose transporter, which is a type of a facilitated diffusion? So guys, what is true about this true about this question? That is option number A. It uses the ATP to move glucose across the membrane, as it is already telling that this is the facilitated diffusion. Facilitated means ATP required or not? Please tell me, ATP is required or not? No, guys. Facilitated means no ATP is required. So this is the protein mediated. So this is the carrier protein mediated. Facilitated diffusions are carrier protein mediated. So no ATP is required. So that is actually false. That is the false statement. Option number B. It moves the glucose from an area of low concentration to high concentration. Guys, if you are going from lower side to higher side on the mountains, do you require the energy or not? अगर आप पहाड़ पे नीचे से ऊपर जा रहे हो तो do you require energy or not? Obviously, you require the energy. So it is telling again that moves glucose from a low concentration to high concentration. No, guys, it always moves from the high concentration to the low concentration. So that is again the false statement. That is again the false statement. Option number C, it allows the glucose to move down its concentration gradient without using ATP. Yes, yes guys. जब आप पहाड़ से नीचे आओगे, if you are moving down, it does not require any energy. So yes, it sent the glucose to move down its concentration gradient without using ATP. And option number D, it requires sodium ions for the glucose transport. No guys. Sodium ion is required for which channel? SGLT. But the question is asking about the GLUT. So right answer of this question is option number C. It allows glucose to move down its concentration gradient without using of ATP. Right, Bida? Without using of ATP. Right? Now coming to the next question. Yeah. So all of you are now master in the ABG. I hope that, and many of the area you studied this ABG, and now you can easily get your answer from this ABG. So please answer for this question number 10. A patient has the following ABG result: the pH 7.55, PCO2 30 mmHg, and the bicarbonate 24 milliequivalent per liter. What is the most likely diagnosis? Yes, guys. Respiratory acidosis, alkalosis, metabolic acidosis, alkalosis. Yes, guys. Yes, my dear doctors. हाँ बेटा जी, बोले सर क्या क्वेश्चन है, क्या एबीजी पढ़ी थी अपन ने क्लास में, मजा आ गया था। अच्छा मेरे को ये बताओ, क्लास में अपन ने जो एबीजी पढ़ी थी बेटा, हैव यू रियली एंजॉयड दैट पार्ट? हाँ, in class when we studied the ABG, have you really enjoyed this ABG? And now many of the area where you have been practice the ABG questions, I hope that now you can easily answer your this ABG part. Yes beta? Okay, wonderful, wonderful, wonderful guys, everybody. Yes, everybody is correct. That's whoever is answering on the live chat box right now, that's everybody is right. Yes, yes. So how we are understanding this part, right? So you can see over here that first of all what we did, first of all we noted that's what are the steps. pH, what is the pH? 7.55. What is the CO2? That is 30. What is the bicarbonate? That is your 24. As we know, the normal value of the pH of the blood, that is 7.35 to 7.45, less than 7.35, acidosis, more than 7.45, alkalosis. So as you can see, this pH is showing the 7.55. It means this is towards which side? This is towards the alkalosis side. Alkalosis side, right? What is the normal value of the CO2? The normal value of the CO2 is 35 to 45, and property of the CO2 is acidic. As you can see, the CO2 is less, means this is also causing the alkalosis. Alkalosis. Talking about the bicarbonate, the normal value of the bicarbonate is 22 to 28, and now you can see the bicarbonate is normal, and the property of bicarbonate is alkaline in its nature. So this is actually the normal. So who is the culprit? Who is changing this pH actually? So we studied in the class, this pH either could be changed via CO2 or either via bicarbonate. So here actually the culprit is your CO2, and for the CO2 we use the word respiratory, and this can causing the alkalosis. So what is the right answer of this question? That is, right answer of this question is option number A, respiratory alkalosis. Right beta? Respiratory alkalosis. अतुल, क्वेश्चन कॉन्सेप्ट याद रहता है बट सर वैल्यू भूल जाते हैं, तो चलो एक बार वैल्यू को याद कर लेते हैं. प्लीज क्लोज योर आइज एंड रिवाइज विद मी गाइस दैट द नॉर्मल वैल्यू ऑफ द pH of plasma or the blood, that is 7.35 to 7.45. 7.35 to 7.45. 7.35 to 7.45. The normal value of the CO2, remove the 7 and what is the remain? 35 to 45. 35 to 45. 35 to 45. 35 to 45. So this is the CO2. Now, this normal value of the bicarbonate is 22 to 28, 22 to 28, 22 to 28, 22 to 28. So, normal value of the pH 7.35 to 7.45, normal value of CO2 35 to 45, normal value of bicarbonate 22 to 28, right? So, I hope now you can easily remember till 12th of January 2025 till your examination day, right? Coming to the next question. A RT patient comes to you in the emergency room. On further examination, you found that he is not feeling of proprioception, tactile localization, pressure sensation from below area on the affected side. But he can feel the pain, hot and cold sensation. Which of the following statement is true regarding this condition? Yes, guys. Yes, guys. Yes. Option number A, ipsilateral loss of sensation if injury to anterolateral pathway, contralateral loss of sensation if injury to dorsal column pathway, ipsilateral loss of sensation if injury to dorsal column pathway, and option number D is ipsilateral and the contralateral loss sensation if injury to anterolateral pathway. Yes, guys. So please answer for this question. This is actually the questions from the Brown-Sequard syndrome, if you can remember. Yes. Yes, guys, please answer. Wonderful, guys. Wonderful. So this question, if you remember how we remember all of this different sensation, guys, remembering? याद आया कुछ क्लास के अंदर what we have been discussed? Yes, guys. How we remember all of this sensation for the dorsal column pathway and the anterolateral pathway, right? Yes. So I hope you can easily remember all of these sensation, guys. देखो कुछ बच्चों के तो चेहरे पे भी मुस्कुराहट भी आ रही है, अभी कुछ बच्चे हंस भी रहे हैं, राइट? मंद ही मंद, अरे सर 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 याद आ गया सर, राइट? Yes, yes. So this is how I remember this and all this sensation, guys, and 100% you can easily remember all of these sensation, guys. Okay? Yes. Yes, 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 yes. Right? But I don't know, Rushik, I don't know about the anatomy mnemonic, but there was a physiology mnemonic was there. And by the name that some of the students even is writing, by the name you can easily remember all this mnemonic, guys, right? So as today we are just taking that MCQ revisions, MCQ practicing session or that high yield area or 25 important series, guys. So I'm not going to explain in a very detailed manner right now in this class. So that is how you can easily remember all of this area, right? So we know that for the sensory sensation, we are having the two pathways. For the sensory sensation, we are having the two pathways for sensory. And these two pathways is number one is dorsal column and another one is anterolateral pathway, which is a part of spinothalamic pathway, right? Spinothalamic pathway. Now, in this anterolateral, again, this is divided into two, anterior spinothalamic and lateral spinothalamic. Anterior and lateral spinothalamic. Guys, in the dorsal column pathway, the sensation which we have been discussed, these sensations were proprioception, 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 fine touch, vibration, tactile localization, 2-point discrimination, 2-point discrimination, and stereognosis. Talking about this anterolateral pathway on the anterior side, so this is for the crude touch and the pressure, and lateral is for pain and temperature. So this is how the different sensation were present. We know that anterolateral pathway, they decussate, they cross over when they are coming from the downside. Ultimately, they need to cross at the spinal cord level. So anterolateral pathway, they cross at the spinal cord level, spinal cord area, and dorsal column pathway decussate at which area, beta? This decussate at the medulla. So they decussate at the medulla, right? So now you can see that if the dorsal column is coming, this dorsal column is going on the same side and then it will decussate at the medulla and then it will cross over and it will give the sensation to this hemisphere. But we know the anterolateral pathway did decussate at the level of spinal cord. It will come to the another side, will go to the upside, and then it will reach to this hemisphere. Because we know that brain is always controlled to the opposite side of the body. So this brain will control this area of the body and this brain will control this area of the body. Now you can easily see this question. The question is saying that this person is not having feeling of what? Proprioception. tactile localization, right? And the pressure sensation on the affected area. This affected area means this is the affected area means this side area. Suppose this side area, person is not feeling proprioception tactile localization, but he can feel the pain, hot and cold. Means this person is having the loss of dorsal column pathway, but the anterolateral pathway is spare. So this is how which of the following statement to regarding this condition. So now you can see if affected side is happening to going to this loss of this sensation, it means this is the ipsilateral side. This is not the contralateral. अगर चोट इधर की लगी है और इधर के ही sensation चले गए, that's we called as ipsilateral. If this side area gets the trauma, but this side area sensation is gone, it means this will be known as the contralateral. So now you can see the dorsal column is always show the ipsilateral loss below the medulla. So you can see that this contralateral part is gone. This contralateral part is gone. Now you left with the two options, the ipsilateral loss of sensation if the injury to anterolateral pathway. No guys, anterolateral always will show the contralateral loss of the sensation, not the ipsilateral loss. Only the dorsal column pathway which will show you the ipsilateral loss of sensation if injury to the dorsal column pathway. So right answer of this question is option number C, right? Option number C, right? Right now, coming to the next question. Coming to the next question, that is the caudate nucleus. Right, beta. So this question number 12, a 40-year-old man comes to the emergency room with complaint of sudden violent hyperkinetic involuntary ipsilateral movements on the right arm and the leg. On examination, patient found hemibellismus. So all this diagnosis is already given. That patient is having what? Patient is having the hemibellismus, identifying the defect area leading to this condition. So this is related to what? This hemibellismus, that athetosis, now Parkinson's, all of these are related to what? Or the chorea, all of these are related to what? They are related to the basal ganglia. Basal ganglia, guys. So this basal ganglia we have been discussed during the classes, and in the basal ganglia we have been seen that hemibellismus is the problem of which area? This is the problem of subthalamic nuclei, guys. Subthalamic nuclei. Very good. Everybody answered very well. This caudate nucleus, caudate and globus pallidus. Yes, guys. There was the putamen, caudate, globus pallidum, subthalamic nuclei, and the substantia nigra. 5 basal ganglia were there. So talking about this basal ganglia, number 1 is putamen, caudate, globus pallidum, subthalamic nuclei, and substantia nigra, and the substantia nigra. Yes, guys, remember? So just understand like this. Write down this caudate to upside because we studied like this: caudate, putamen, globus pallidum, subthalamic nuclei, and the substantia nigra. Right, guys? Now, combinedly this putamen and the globus pallidum, this is actually making what this we call as lentiform nucleus. What we call this? Lentiform nucleus. And combinedly this caudate and putamen we call as striatum. Problem of caudate, we can know that this is the this pathological condition which happens due to the problem of the caudate we call as chorea. Then similarly, athetosis due to the globus pallidus, subthalamic nuclei can lead to the hemibellismus. And in the hemibellismus, when this person is sitting in front of you, this person will not able to stop that's half portion of the body, and this person will involuntary will show the movements like this of the half area of the body. That's we call as hemibellismus. This hemibellismus is the problem of problem of subthalamic nuclei, and the which neurotransmitter is going to be defect in the subthalamic nuclei. The neurotransmitter which is defect in the subthalamic nuclei is glutamate. Glutamate, very important. Subthalamic nuclei contain which neurotransmitter? Glutamate, right beta? Glutamate. So I hope that now you can remember that is the glutamate. Substantia nigra, this condition what? That is can cause that Parkinson's disease. Parkinson's disease. This can causes Parkinson's disease, right? Which neurotransmitter is required? Dopamine, right? Dopamine. Okay. So basal ganglia, very important. You should remember about the basal ganglia, right? Coming to the next question. The question number 13. A 50-year-old male is brought to the brought to the neurology department by his wife. That she complains that her husband is not able to understand the spoken words. On further evaluation, he has no difficulty to speak and write people name. It could be a lesion in which area of the brain? Yes, guys. Yes. Please answer for this question. Option number A, Broca's area, arcuate fasciculus, Wernicke's area, and the angular gyrus. Yes. Now, yes, please answer for this question number 13. A 50-year-old man is brought to the neurology department by his wife. So she complains that her husband is not able to understand spoken words. So what is the catch? Understand the spoken words. On further evaluation, no difficulty to speak and write people name. It could be a lesion in which area of the brain? So we know, we studied the different area of the brain, and that is, if you remember, that this frontal area is contain what? This frontal area contain the motor speech area, that's we called as Broca's area. So this is your Broca's area, right? Another area is present into the temporal lobe, which is present over here, and this area we called as Wernicke's area. Wernicke's area. The Broca's area is responsible for motor speech. Wernicke's area is responsible for sensory speech. What is the sensory? Comprehension of the language. If whatever I am saying right now, you are able to understand this part. Why? Due to the presence of this Wernicke's area. But now I am speaking. This is my motor speech. This is my motor activity. So this could be possible due to the Broca's area. Now you should make a coordination between both of these areas. So for the making the coordination, there is a coordination fibers are present which is connecting both of these areas like this, and these fibers are we called as arcuate fasciculus. Arcuate fasciculus, right? And basically they are taking the conduction of the speech. So whatever you are hearing, then you will answer. So this is called as conduction of the speech is done by the arcuate fasciculus. Now, if the Broca's area is gone, this area can lead to what, guys? If the Broca's area is gone, this area can lead to the motor aphasia. Motor aphasia, which is also called as non-fluent aphasia. Non-fluent aphasia. The Wernicke's area, if this area is going to be damaged, this can lead to the sensory aphasia, which is also known as the fluent aphasia. Fluent aphasia. But if the arcuate fasciculus is gone, this can lead to the conduction aphasia. Conduction aphasia means person can able to listen, person can answer, but there is no coordination. Whatever you are saying to the person, this person will not give you the appropriate answer. So this is called as conduction aphasia. आप पूछोगे क्या, वो बोलेगा क्या, right? Now, if suppose all of this area is gone, this condition we called as global aphasia. What we call this? Global aphasia. So all this area could also be damaged. So now this we called as global aphasia, right, guys? So here you can see the question is saying not understand to spoken words. So means this right answer of this question is problem in Wernicke's area, right? Problem in Wernicke's area. Coming to the next question. A patient is having the atrial myxoma admitted in your hospital. Which JVP will which JVP finding will present in this patient? Large C wave, large V wave, large A wave, and the absent Y descent. And the absent Y descent. Yes, guys. Yes, please answer. Yes. Yes, please answer. Mm-hmm. Large C wave, large V wave, large A wave, and the absent Y descent. Yes, many of you are saying. If you are saying that's option number D, if you are saying that option number C, guys, what is the first of all you should understand what is the atrial myxoma. Guys, suppose this is your heart, these are the chambers. This we know, right atrial, left atria, right ventricle, left ventricle, guys, right? Right, atrial myxoma means suppose if this right atria is having some tumor like structure over here. Suppose this tumor is formed over here. This we called as atrial myxoma. Guys, if the tumor is occurs into the right atria, what is the space inside of this right atria? Increase or decrease? Obviously, this is the having less area inside the right atria. Now what will be happen? Now when the venous return will be happen, when the blood will comes from the veins, this blood will falls down over here, and we know in the JVP there are the different waves. There is the wave that we called as ACVXY. A is due to atrial contraction, C is due to tricuspid bulging, X is due to that's atrial relaxation, and that's next is your V wave, that is due to the venous filling, and the Y wave due to the atrial emptying into the ventricle. So we know that part, we understood already in the class. So atrial myxoma, if the less space in the right atria, what will be happen when this blood will accumulate into this area? This area is already having some mass inside of this, so the right atria pressure during this time will be very high. And now what will be happen when this right atria is going to be contract, the pressure will go very high, and this very high pressure will show you what? That's it will show you the large A wave. What it will show you? It will show you the large A wave. तो देखो बेटा, जब राइट एट्रिया के अंदर ऑलरेडी कुछ एक्स्ट्रा स्पेस ऑक्यूपाइंग एरिया है जो अंदर से कुछ ग्रो कर गया, so this is having the less space. Now what will be happen? This area when going to be contract, this is having very severe pressure inside of it, so this will show you the large A wave, right? So this will show you the large A wave. So right answer of this question is large A wave. Now this question, the next part is that different waves. Absent A wave. Absent A wave you can see during the atrial fibrillation in the JVP, and absent P wave in the ECG you will see again in the AF, that is atrial fibrillation, right? Now the next is your next question is which of the following brain waves pattern is most commonly observed in a person who is awake but relaxed with eye closed? Yes, guys. Now please tell me. Now please tell me. Yes. Delta, theta, alpha, or beta? Yes. Yes, guys. Please answer. Which of the following brainwave pattern is most commonly observed in a person who is awake but relaxed with eye closed? Yes. Yes. So remember, in the EEG waves, we have been studied when right now you are awake. You are awake, you will show the beta wave. Once I'll ask you, please close your eyes. Right now, you just close your eyes. You are not sleeping. During this time, your brain activity is slightly decreased. Right now, the wave which we'll see on the EEG, that is our alpha wave. Now, when you start entering into the light sleep, you will show the theta wave, and when you enter into the deep sleep, you will show the delta wave. Now, on the 12th of January, when you are highly focused at 9 a.m. in the morning till 4:30 p.m. in the evening. During this time, if I'll check your brain activity, your brain will show very highest activity. आपका brain पूरा इधर से उधर जो tsunami चल रही होगी अंदर, and your brain will have highly active condition. During this time, if I'll see the wave on the EEG, that's we called as a gamma wave. So again, revise with me. When you are awake, you are doing your work, you will show the beta wave. You close your eyes, but you are awake. Now you will show the alpha wave. Into the light sleep, theta wave. Into the deep sleep, delta wave. And during the highly focused condition, you will show the gamma waves, right? Gamma waves. Now, there is the sleep cycle. In the sleep cycle, there is two pattern is there. Also remember about the sleep cycle. So sleep is having two cycles, two type of cycles, NREM and the REM. NREM stands for non-rapid eye movement and REM stands for rapid eye movement. NREM again is for N1, N2 and N3, and out of this maximum sleep cycle is NREM2. This REM means person is sleeping, but person is thinking that this person is awake. And now sometimes when we sleep, we think that we are doing whatever we are seeing, whatever dream we are seeing, this is actually happening into the real life. ऐसा ही होता है बेटा कि कई बार अपन सोते और अपने को लगता है अरे ये तो मेरे साथ में रियल में हो रहा है. This person is actually sleeping, but this person is thinking that thing is happening into the real. This is called as a rapid eye movement sleep. If this person is thinking that I'm doing all of this part into the original or in the live condition, the waves which you will see in the REM, again the beta like wave. Beta like wave. So very important part, that's REM sleep will show you the which type of wave, beta like wave, right beta, beta like wave. Now, so right answer of this question, that is that alpha wave, option number C, alpha wave. Coming to the next question, the lesion in ventromedial nucleus of hypothalamus typically lead to hyperphagia and obesity, anorexia and weight loss, insomnia and the sleep disturbance, excessive thirst and the urination. Yes guys, please answer. Yes guys, please answer. Hyperphagia and obesity, anorexia and weight loss, insomnia and sleep disturbances, excessive thirst and the urination. Yes. To answer this question, you should remember all these different nucleus of the hypothalamus, which we have been discussed during the classes, right? So you know that hypothalamus is having various type of nucleus, and in this various type of nucleus is one is suprachiasmatic nucleus. Remember guys, suprachiasmatic nucleus. This suprachiasmatic nucleus is responsible for what? Circadian rhythm. This is actually your biological clock. This will give you an idea when you have to awake, when you have to sleep. So this circadian rhythm is actually this managed by the suprachiasmatic nucleus, which releases what? This is happens regulated via the melatonin, which is releasing from the pineal gland. Then number two, we also discussed that lateral nucleus. Lateral nucleus, this is your what? Hunger center. Hunger center. Then we also discuss ventromedial nucleus, and ventromedial nucleus is for satiety center. Satiety center. What is the meaning of satiety center? कि बस अब मैंने खाना खा लिया है, मैं और नहीं खा सकता. I am right now full, can't eat more. So this signal how you are getting? You are getting by the ventromedial nucleus, which is giving you the satiety center. When you want to eat, you want to eat something, lateral nucleus will give you the signal. So this is the hunger center. Now for also we have been discussed that lateral preoptic nucleus. Lateral preoptic nucleus, right beta? Lateral preoptic nucleus. This is for thirst center, thirst center, thirst center, and the paraventricular nucleus. paraventricular nucleus. This is for oxytocin. Paraventricular nucleus for oxytocin, and the supraoptic nucleus. Supraoptic nucleus, this is for ADH. This is for ADH. So these are the different nucleus are there. So now you can easily get your answer. That question is saying that problem at which area? Ventromedial nucleus. Means what is happening, guys? This ventromedial nucleus is gone. Means what is person is not able to feel the satiety. Nobody is there. That now you stop eating. So what will be happen? This person will only eat and eat and eat. और जब आप जरूरत से ज्यादा खाओगे, so what will be happen? You will be happen like me, like obese, right, beta? So right answer of this question is hyperphagia and the obesity. Right, anorexia and weight loss, this could be possible in which condition? When person is what having? Person is having the problem in the lateral nucleus. Now nobody is there to tell that you need to eat something. So if the problem in lateral nucleus, no hunger cannot be sensation feel via this person, so person will have the weight loss. Insomnia and sleep disturbance, this could be happen when the suprachiasmatic nucleus is going to be damaged, and the excessive thirst and the urination, this could be possible via the supraoptic nucleus problem. Right, now the one mnemonic you can remember, the mnemonic we called as SOAP. What we call this? We called as mnemonic, we called as SOAP. SOAP. What is this mnemonic? This mnemonic stands for that S means supraoptic nucleus, and this S is for A and O is for P. Means supraoptic nucleus regulated the ADH, and the paraventricular nucleus will regulate the oxytocin. So don't be forget this mnemonic SOAP, SOAP. I hope you can easily remember. Right, beta? Right. Now coming to the next, a patient present with loss of coordination, intention tremor, and the dysmetria, means inability to judge the distance, past pointing, which suggests a lesion in the, right, beta? Which suggests a lesion in the, please answer me for this question. Basal ganglia, cerebellum, spinal cord, or the primary motor cortex? Yes, guys. Please answer for this question. That's this person is loss of coordination. Loss of coordination means this person, if you ask that please do the repeated functionality like this person cannot do something like this. That's we called as what? That's we called as dysdiadochokinesia. Right, so this person will not able to do the alternative motions, that we called as dysdiadochokinesia. Intention tremor, again, you know, if even you know the what is the intention tremor is the problem of, this is the problem of cerebellum. This is the problem of cerebellum, right? And the dysmetria or any other things like this person is also having the gait disorder, ataxia. These all are the problem of which area? That is the cerebellum. Cerebellum we also called as small brain, chota magaj, and this cerebellum is having the different structure. This cerebellum is present like this. In the middle portion, this we called as vermis. Now outer zone, this is your outer zone area like this. This is suppose your cerebellum. On the downside area, this is containing the another structure over here, right? Now this is we also called as vestibulocerebellum, right? Vestibulocerebellum. This another area which is present inside of this area, that's we called as spinocerebellum. spinocerebellum, and this two portion we called as neocerebellum. Neocerebellum means these are the new areas, so we called as neocerebellum, right? Now this neocerebellum, this is actually for what the functionality of this neocerebellum is. It required for motor and the premotor motor and the premotor cortices. This is required for that, means the motor planning, or you can say like the motor planning. Then this vestibulocerebellum, this is required for balance and eye movements. Balance and eye movements, which is also called as flocculonodular lobe, which is also called as flocculonodular lobe. Flocculonodular lobe. This area is required for what? This required for the posture control. And this area is required for control the skilled movement. Control skilled movements. So this is how this cerebellum can do the various functionality in the body. So this is how the different areas, spinocerebellum, neocerebellum, and the vestibulocerebellum, that is we also called as flocculonodular lobe, and that is we also called as the older name we called as archicerebellum. This is archicerebellum. This we called as paleocerebellum because this is the older structure. So this is the paleocerebellum. This is we also called as archicerebellum. So these are the different names, right? So all of these conditions, the coordination, intention tremor, dysmetria, dysdiadochokinesia, ataxia, gait disorder, all of this condition is actually happens due to the problem in cerebellum, right beta? Cerebellum. Now coming to the next question. Which of the following is the most powerful stimulus for triggering an increase in ventilation via the central chemoreceptor? Right, guys? Yes. So question number 18, options are hypoxia, hypercapnia, alkalosis, and the hyperglycemia. So please answer for question number 18 now. Right, guys? Yes. What's the most powerful stimulus for triggering an increase in ventilation via the central chemoreceptor? Yes, guys. Remember, I told you the two type of chemoreceptor. One is in central, another one is peripheral. And this peripheral is actually present in which two area? This is present into the carotid artery and another one is present into aorta. So one is present in carotid artery, another one is present in aorta, and now you can easily remember that this peripheral chemoreceptor, the most powerful stimulus for this area is hypoxia, means decreasing in O2 in the blood. And this peripheral chemoreceptor, this is a special cell called as glomus cell, which is containing potassium ATPase sensitive channel. Right? Which is containing the glomus cell. So whenever there is a low oxygen in the blood, immediately this area will be fire. It will give the signal to the brain, and this brain will increase the respiratory rate. But talking about the central chemoreceptor, they are located into medulla. And the direct stimulus for this area is actually the direct stimulus is H ion, but the uh, indirect stimulus is CO2. CO2. So if the level of CO2 will be increased in the brain, immediately this will give you the trigger point for the central chemoreceptor activation, and immediately the brain will increase the respiratory rate. So you can see that most powerful stimulus according to this option, that is the hypercapnia. So right answer of this question is option number B, hypercapnia. If this is not asking the central chemoreceptor, if it is asking the peripheral chemoreceptor, then the answer could be the hypoxia, right? Hypoxia, right? So this is how the different condition for this central and the peripheral chemoreceptor. Coming to the next, during a physical examination, a 30-year-old female is found to have a physiological heart sound that occurs shortly after the first heart sound. And it is best heard at the apex of the heart. This sound is low pitched and it is indicative of rapid ventricular filling. What is the likely heart sound being described? Right? S1, S2, S3, S4. Yes, guys. S1, S2, S3, S4. Yes. Yes. Please answer for question number 19. So as you can see, the S1, S2, S3, S4, this question is saying, talking about of what this is talking about. This is not the pathological sound. This is the physiological heart sound. Physiological means normal sound, and this is occurs when shortly after the first heart sound. Then where, what is, in which condition this is happening? In the rapid ventricular filling, right? Rapid ventricular filling. So guys, I told you that's in the rapid ventricular filling, the first rapid ventricular filling will cause which heart sound? S3 heart sound. So this first rapid ventricular filling is S3, and the second rapid ventricular filling will causes the S4, right? S4. So this is happening just after the first heart sound, right? First heart sound means when the AV valve will be closed. During after this time, the S3 will be appear. So the right answer of this question is S3, right? S3. So this could be seen in the anemic patient, in the pregnancy, in the exercise, during the exercise. So all of this condition can show you the S3 heart sound, right? S3 heart sounds, everybody is right. Coming to the next question. The Bain bridge reflex is primarily mediated by which of the following mechanism? Yes. So now talking about the Bain bridge reflex. Option number A, increase in blood pressure leading to vasodilation, stretching of arterial walls due to the increased venous return, activation of carotid chemoreceptor, and the increased sympathetic output to the heart. Yes. Yes. Please watch this question properly and then answer me. Yes, dear. Answer carefully for this question. Yes, guys. So, what is the Bain bridge reflex? Remember, guys, in the heart, we have been discussed in the CVS, we have been discussed that three reflexes were there. Number one, the Bajol-Jaris reflex, then the Bain bridge reflex, and then the Cushing reflex. Right? So, please pay attention over here. Suppose this is your heart. This is your heart. This is your heart. In this heart, again, this is the right atria, left atria, right ventricle, and the left ventricle. I told you that two most important chambers for the heart are there. That is, number one is right atria and another one is left ventricle. Left ventricle, why? Because this is the cardiac output is depends on the left ventricle area, and all the venous return which is coming back, this blood coming back into the heart, that is actually falling down into which area? Into the right atria. So this right atria region is becoming very important for receiving the blood into the heart, and left ventricle area become to taking blood out from this heart. So that's why the two chambers are very important. Guys, there could be a possibility. The number one possibility could be there, that suppose this left ventricle are not able to function properly, isn't it? What could be happen if this left ventricle become weak? This left ventricle will say, I am very much weak. I can't pump that much of blood from this area. So what will be happen? This message should be go immediately to the brain. This message should go immediately to the brain, and this left ventricle should tell to the boss that, boss, I am very much weak. Please don't force me to do the more functionality because I'm not having that much of power. This brain will get this message, and this brain will immediately tells to this left ventricle and give the confirmation that don't worry, I will not force you to do any function. And what this brain will do? This brain will never do the increase in the heart rate, and that is how this heart rate will always remain less, can lead to the bradycardia. And this reflex, you can see the message is going to the upside, and upside confirming this message and coming back. So this is a type of reflex. This reflex we called as Bejold-Jares reflex. Bejold-Jares reflex, right? Bejold-Jares reflex. And this Bejold-Jares reflex, we can also call it that bradycardiac reflex, right? And this could be happen in which condition? This could be happen during the MI or the hemorrhage, right? Now, the another reflex could be there. And what is the another reflex? The another reflex when there is the problem in the right atria. And what could be the problem into the right atria could be there, guys? Yes, please tell me. What could be the problem in right atria? The right atria can receive more amount of the blood. Zyada blood aa gaya. If it will receive more amount of the blood, right atria will say, why this extra blood is coming? If the right atria will get more amount of the blood, guys, this right atria can't get this blood back from this area. Ultimately, this right atria need to pump this blood to the downside, and so that this right atria send this message to the boss and tells to the boss, I am getting more amount of the blood. And if this message reached into the brain will immediately send the signal to the right atria and increase the right atrial contraction, can lead to the tachycardia. So that is how you can see the one reflex which is giving the bradycardia and another reflex which is giving the tachycardia, and this will increase the heart rate leading to tachycardia. This reflex we called as Bain bridge reflex. Remember, this is not the brain, this is the Bain, B-A-I-N, this is the Bain bridge reflex. So this is also called as tachycardiac reflex, right, beta? Tachycardiac reflex. So now you can easily understand what is the Bain bridge reflex. So please answer now, what is the Bain bridge reflex? The Bain bridge reflex is reflex when there is a stretching of atrial valves due to increased in venous return. That is the right answer of this Bain bridge reflex. So I hope now everybody can easily understand why option number B is correct. Increasing in blood pressure leading to vasodilation. This is not the function of this Bain bridge reflex. This is actually the function of what? This is the function of your baroreceptor. Baroreceptor, right? For sensation for this BP. Now, activation of the carotid chemoreceptor. This is for the respiration. Chemoreceptor related to the respiration. Increase sympathetic output to the heart, right? Increase sympathetic output to the heart. It is actually happening via giving the message to the brain. But how this message is going to the brain? This message is going due to this condition, and then only this message is coming. So this is happening like this. So what is the first step? First step, sending the message to the upside, and this is happening due to the stretching of atrial valves due to the increased venous return, and then there is the increase in sympathetic output to the heart. So then this step is coming. So best choice out of this all the options, that is option number B, the stretching of atrial valves due to the increased venous return. Coming to the next question, that which of the following is a characteristic feature of the histotoxic hypoxia, right, guys? So now please answer, right, guys? What is the right answer of this question? Which of the following is the characteristic features of the histotoxic hypoxia? The option number A, that's normal blood oxygen levels but inability of tissue to use oxygen. Option number B, low oxygen levels in the blood due to low lung function. Option number C, inadequate hemoglobin levels to carry the oxygen. And option number D, that increased carbon dioxide levels due to the impaired ventilation. So please, yes, guys. So please answer for question number 21. Yes. First, you should understand what is the hypoxia. So, as we have been discussed many times in the class, suppose this is your lungs, these are your lungs, and this is your blood vessel. This is your blood vessel, and this is the cell. We know that oxygen is present at this area. This oxygen, first of all, should enter into the lungs. It need to mix into the blood via the hemoglobin, and then it need to be travel over here, and then it simply diffuse inside of the cell via diffusing the cell membrane. Once the oxygen will reach into this inside of the cell, then only this cell will utilize this oxygen and will produce the ATP. But whenever this cell is not able to receive the oxygen, doesn't matter whether the oxygen present is over here, present is over here, or present is over here. If the oxygen is absent inside of this cell, that means this condition we call as hypoxia. So first of all बेटा ये कभी मत सोचना कि hypoxia means less oxygen in the blood. Hypoxia means that less oxygen inside the cell. What could be the possible reason? The number one possible reason that there is no oxygen in the air, or either these lungs are defective. Then no oxygen could be enter over here, so no delivery will be happen at the cellular level. This we call as hypoxic hypoxia. Another possibility is, suppose if this area does not contain sufficient hemoglobin, hemoglobin like a taxi for the oxygen, this taxi is not there, where this oxygen will sit, again the less oxygen delivery will be here at this area, called as anemic hypoxia. Number three possibility, if this area get damaged or this area become narrow, this condition will not allow to move more oxygen beyond this area, that we call as stagnant or ischemic hypoxia. And if the cell membrane is damaged, doesn't matter how much oxygen is present over here, this can't diffuse from this area. So that is how this condition happens at the level of tissue, called as histotoxic hypoxia. So what is happening in the histotoxic hypoxia? In histotoxic hypoxia, the amount of oxygen in the blood is adequate. There is no drop down of the oxygen in the blood, but this oxygen is not able to enter inside of the cell, can leading to the histotoxic hypoxia. So now we can easily answer what is the characteristic features of the histotoxic hypoxia: that normal blood oxygen level but inability of tissue to use oxygen. So right answer of this question, that is option number A. Then talking about the option number B, low oxygen levels in the blood due to the low lung function, that can lead to the hypoxic hypoxia. Inadequate hemoglobin levels to carry the oxygen, that is the possible reason of anemic hypoxia. And increased carbon dioxide level due to the impaired ventilation, right? Impaired ventilation. Again, this is hypoxia, right? Now, so this is how all of this condition could be there, or you can say this is not appropriate for this hypoxic hypoxia, right? So right answer of this question is option number A, that is normal blood oxygen levels but inability of tissue to use oxygen, right? So I hope everybody is clear now. Coming to the next. Question number 22, that's which of the following statement is true about the surfactant in the lungs? Very, very important part, very important topic, surfactant. Every time one question is going to be asked from this topic. So guys, you should not miss this surfactant, right? Option number A, surfactant is present in the airways but not in the alveoli. Surfactant production increase as gestation progress. Surfactant production peaks at birth and then declines, and the surfactant reduce the compliance of the lungs, right? So please answer for this question. What is the right answer for this question? Which of the following statement is true about the surfactant in the lungs? Yes, dears. Please answer. Please answer. Yes. Question is asking not accept. Question is asking what, guys? Please first of all focus. Question is asking statement true. True. What is it true about the surfactant? थोड़ा सा twist है. But yes, some of you are answering correctly. Very good. Very good, guys. Well done. Many of you are now answering correctly. The right answer of this question is surfactant production increase as the gestation progress, right? So what is the surfactant? Guys, first of all, please pay attention. These are your alveoli. These alveoli contain two type of pneumocyte. These are containing two type of pneumocyte. Type 1, type 1, which is required for the gas exchange, and another one, the small pneumocyte, that is type 2, which is actually produce the surfactant. And this surfactant is actually the oily product which is making the layer inside of this alveoli like this, because this alveoli contain the water inside of this area. Water layer is present, and water always put the pressure on the surface, and this pressure we call as surface tension. Surface tension. Guys, the function of this alveoli is that when air entering into this alveoli should be inflate. Then this alveoli should be deflate. But if the alveoli is need to be inflate, means the surface tension should be decrease. Then only the surface, then only this alveoli could be inflate properly. Now this surface tension which is happening due to the layer of water, it need to be counter, and this could be done via putting a oily structure inside of this alveoli, and this oily structure we called as surfactant. Surfactant. The most common surfactant, that is your DPPC, which we also called as lecithin. Lecithin. This DPPC stands for dipalmityl phosphatidyl choline, and the function of this surfactant is only the two function. It decrease the surface tension and it increase the compliance. Guys, what is the meaning of compliance? The compliance meaning means the stretching. Means if we want to stretch this alveoli, we require the surfactant, and we need to decrease the surface tension, and that is the job of this surfactant. The surfactant, this is mainly made up from the phospholipid, and which phospholipid? Dipalmityl phosphatidylcholine or the lecithin. Guys, this start production around the 20 to 24th week of intrauterine life of the babies, but then it is going to be increased more. By the 28th of week, it will start appearing in the amniotic fluid, and at the 32nd week it will be maximum. So you can see, by the age or gestation age is progressing, the surfactant is going to be increased, isn't it? It is going to be increased, right? And if this surfactant is not producing inside the baby's lungs, what will be happen? After the delivery of these babies, this baby alveoli cannot able to function properly, and this condition we called as respiratory distress syndrome, also called as hyaline membrane disease, right? So hyaline membrane disease. So that is why this surfactant become very, 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 very important. This surfactant always increase with the help of cortisol, that is the steroids. So that's why if any diabetic mother is there, we always give the steroid injection during the labor, so that there is an adequate production of the surfactant in the baby's lung. But this surfactant is decreased by the insulin. Which hormone decrease? Which hormone decrease the surfactant? This is your insulin. Insulin. Which increase? This increase via thyroid hormone. Thyroid hormone. This is increased via cortisol. So all of they are going to be increase the surfactant. So that is how the different part of the surfactant is there. So I hope that now you can easily understand. This is your major surfactant. This is your major surfactant. The minor surfactant is sphingomyelin. What is the minor surfactant? That is your sphingomyelin. So guys, please remember, we always do, you studied in the PD as well, there is a LS ratio. So this LS ratio is called as the lecithin sphingomyelin ratio. Lecithin sphingomyelin ratio, that's we measure for the fetal lung maturity test. Fetal lung maturity test. Right, beta? Now coming to the next question. So look at over here, that surfactant production increase as the gestation progress. That's we know that is the true options. Surfactant is present in airway but not in alveoli. No guys, this should be present inside of the alveoli. Surfactant production peaks at the birth, then declines? No, it increased by the gestation age increasing. And the surfactant reduce the compliance? No, it increase the compliance, right guys? It increase the compliance, not reduce. Coming to the next, that which ion channel can be found in the arrow marked area in the given image of the nephron. So guys, actually the image is not containing any arrow, so I am putting the arrow over here. So this is the arrow, right guys? So this is the arrow now. Now please answer for this question. Yes guys, which ion channel can be found in the arrow marked area in given image of nephron? Dear, if surfactant is increasing, it is immediately degraded via GMCSF, granulocyte macrophaging colony stimulating factor, right? So please answer for this question. Which channel is present in this area? Yes, yes, beta, yes. Please answer. कौन सा channel है यहाँ पे? Which channel is present over here? This area containing which area that is your ascending limb of loop of Henle, and you know this area contains the channel we called as NKCC. Which channel? NKCC, which stands for sodium potassium 2 chloride symporter. Sodium potassium 2 chloride symporter, and you know that ascending limb is only permeable for ions and the descending limb is only permeable for water, right? Now also tell me this area containing which channel? This area containing the sodium chloride channel, that is your DCT. SGLT2 is present in which area? This is present in PCT, and ENaC in late DCT and the collecting duct, right? Late DCT and the collecting duct. Very good. So I hope you can remember all of these channels. Very, 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 very important, guys. Now please tell me, what could be happen if the problem in this area? Which syndrome? Which syndrome can leading to this area? You know, this is your Bartter syndrome. Which is syndrome? Bartter syndrome. If the problem into this area, that is your NaCl channel, is going to be defect, this we called as Gitelman syndrome. Gitelman syndrome. If the problem into this area, that is the PCT, that's we called as Fanconi syndrome. And if the problem into this area means the ENaC channel which is present over here, if this ENaC is overactivated, which is ideally should be closed, if this ENaC is going to be overactivated, this condition we called as Liddle's syndrome. So in this Liddle's, what is happening in the Liddle's, the activity of ENaC is going to be increased, but in the rest of the syndrome, all the activity of this channel is going to be decreased. So that's why this Liddle's we also called as gaining syndrome. What we call this? We also called as gaining syndrome, right guys? Gaining syndrome. So these are the different channels which you need to be remember, and also in the pharma you studied all of these diuretics of these areas, and I hope all this aldosterone functionality and the ADH functionality now can easily remember while remembering this nephron image. तो बेटा ये तो आपको याद होगी, right? अच्छे से याद होगी, I hope so, and you are not going to be forget anymore this area. So this is how this nephron is containing the different channels. Mehtab, I did not get you guys, dear. Which stage you want to revise? Okay, regarding that syndrome, okay, I'm writing over here. This area, proximal tubules, if going to be defective, Fanconi syndrome. This is the Fanconi syndrome. Distal tubule, this can lead to the Gitelman syndrome. Gitelman syndrome. This area, if defective, this we called as Bartter syndrome. And if collecting duct which is containing the ENaC, if these are overactivated, then this we called as Liddle's Liddell's syndrome. This we called as Liddell's syndrome. This we called as Liddell's syndrome. Right now, coming to the next question, that which of the following condition would most likely cause a decrease in the GFR? Yes, dear. Which of the following condition would most likely cause a decrease in the GFR? Right. So in the GFR means suppose this is your glomerulus and this is your afferent arteriole. Sorry, Bowman capsule. This is the glomerulus, afferent arteriole, glomerulus, and this is your efferent arteriole. So afferent arteriole, and the glomerulus, and this is your Bowman capsule, right? So in which condition the GFR is going to be decreased? That's what the question is asking, right? So please see one by one option. Number one, increase in cardiac output. Dear, if the cardiac output will be increased, what will be happen? This cardiac output means more blood will come over here, and if more blood will come over here, more filtration will be happen. So ultimately, it will increase the GFR. So this is wrong option. Option number B, decrease renal artery resistance. Renal artery resistance means if the more blood will come, if this is going to be dilate, and if more blood will come, more filtration will be happen. So again, it will increase the GFR. So again, this is the wrong statement. Increase in sympathetic nervous system activity. Yes, whenever there is a nervous system, sympathetic nervous system is activated, this will always do the vasoconstriction. It means this area is going to be constrict, and if this area is going to be constrict, less blood will come and less filtration will be happen. So it means this is the right option. Means increased sympathetic nervous system activity will decrease the GFR. Number 4, increase hydrostatic pressure in the glomerulus. Means if this area is having the pressure we called as glomerular hydrostatic pressure, means that is the favorable for the filtration. So if this pressure is going to be increased, what will be happen? That more filtration will be happen. It means GFR is going to be increased, not decrease. So what is the right answer for this question? The right answer for this question is option number C, that increased sympathetic nervous system activity could decrease the GFR. Rest all the activity, they will increase the GFR. Right, beta? How you can actually measure this GFR? So guys, please remember that GFR can be measured most appropriately via inulin, that is best, or you can say not best, you can say most appropriate. But as the inulin is dye, so this you need to take from the outside. Most commonly used, that is creatinine, that is most clinically used. That's why we always take the serum creatinine level whenever we are measuring the KFT, kidney function test. And the best is cystatin C, that is the best. And this is also, you can say, this is the new marker. This is the new marker, right? So cystatin C is best, and this is the new marker. So this is how you can measure the GFR. The normal GFR is 125 ml per minute by the both kidney. 125 ml per minute by the both kidney. So that is your GFR, right? GFR. Now, coming to the next, the question number 25th, that which part of the nephron is responsible for the maximum reabsorption of water in presence to antidiuretic hormone? PCT, loop of Henle, DCT, and the collecting duct. Please answer for this question. Yes, guys. What will be the right answer? Yes. What will be the right answer? Yes, dear. Please answer for this question. Yes. Which part of the nephron is responsible for the maximum reabsorption of water in presence to ADH? First of all, tell me from where this ADH is going to be released? This ADH is going to be released from the posterior pituitary, posterior pituitary gland. Right now, this ADH will go over there. It will come at the collecting duct. To the collecting duct, there is a receptor, extracellular receptor, that's we called as V2 receptor. This V2 receptor, this V2 receptor will function over here. This will function over here via the secondary messenger, and the secondary messenger is CAMP, right? So this is how this ADH is actually functions. So this ADH is coming. This is how this ADH is function via the V2 receptor. Now the question is asking which part of the nephron is responsible for maximum reabsorption, the maximum reabsorption of water in presence of antidiuretic hormone. Yes, antidiuretic hormone. Yes, guys. So many of you are answering that, sir, this is actually what? This is your collecting duct. But no, dear, this is not the right answer. I told you that maximum reabsorption of water or any other substance into the nephron, this always happens in which area? This always happens into the PCT. चाहे कुछ भी हो जाए, that maximum water reabsorption, maximum glucose reabsorption, maximum bicarbonate reabsorption, it always happens into which area? PCT. So guys, this question is repeatedly asked in your exam. You should not forget this question. You should keep your mind open during your examination, and then only you should answer each and every question, guys. So I hope all of these questions help you a lot. And now I'm going to one more announce for the non-Mistian students, the students which are not enrolled into the MIST Institute, but right now they are watching this video, guys. I would like to announce one thing, that MIST is presenting a free mock test for 12th of January FMG exam, and this free mock test is going to be held on 6th of January 2025. This test is, again I'm repeating, this is a free mock test, and this is exclusively for non-Mistian students, means those who are not registered or not studying in the MIST. Those can also get an experience of the MIST, and you can give this mock test on the 6th of January on Saturday from 9 a.m. to 1 p.m. There will be the mock test part 1, and the 2:30 to 5 p.m. there will be the mock test part 2. So guys, this is how you will get your test over here. So you can give this test by between this timing, and exclusively this is for the non-Mistian student. The MIST student, you should not give this test, because all you are getting these questions into your 4 mock tests which you are getting via this MIST. So I again announcing this part, that for the non-Mistians you are getting a free mock test which is exclusively conducting via the MIST, and this is just regarding to make them more prepared for the 12th of January examination, right guys? So you will get the registration for that part. You should register, then only you will get your test IDs and everything. And this test ID either you can take from the MIST team, you can get the number over here, or also this message can be circulated in the various platforms, so you can easily get the scan QR code for the registration. So this is the one announcement which I would like to make for all of the students right now who are watching, whether they studied in the MIST or not, because this is a very important to pass this exam, guys. Now one more thing, I wish you to all of the lovely students a very happy new year, guys, because today is 30th of December 2024, and tomorrow is the last day of this year, and then we are entering into the new year. I wish to all the students, that you are having a very good luck for your 12th of January 2025 examination, and may God give you all the student beta that you can come with your flying colors and you make to proud to yourself, to your parents and to your lovely teachers. So I wish that all of you are going to pass on the 12th of January FMG examination guys. बस बेटा लगे रहो और दम लगा के बस पढ़ते रहो, डरना नहीं है, ये नहीं सोचना है कि 12 जनवरी को एग्जाम में क्या आने वाला है। जो भी कुछ एग्जाम में आएगा, जैसा भी आएगा, यू प्रिपेयर्ड अ लॉट बेटा, आपने बहुत हार्ड वर्क करा है, आपने बहुत शिद्दत से मेहनत करी है। आप सोच के देखो, जब आप पहली बार इंडिया आए थे आपको कितना आता था और आज आपकी पोजीशनिंग क्या है बेटा। आपको बस घबराना नहीं है बेटा, आपके पास में वो सारी कैपेबिलिटी है। यू कैन क्रैक दिस एग्जाम विद एनी कॉस्ट, विद एनी कंडीशंस, but only just to require, you just need the consistency and the honesty guys. इन 10 दिनों में अपने आप को टूटने नहीं देना है, डरो मत, अपने अंदर डर को बाहर निकाल दो और अपने से कहो ऑल इज वेल, ऑल इज वेल, ऑल इज वेल। आपने ऐसे एग्जाम जिंदगी में बहुत सारे दिए हैं और ऐसे एग्जाम आप जिंदगी में आगे भी दोगे, बस आपको अपनी कंसिस्टेंसी दिखानी है और अपने मन पे विश्वास रखना है कि यस यू आर गोइंग टू पास दिस एग्जाम विद एनी कॉस्ट। आप इस एग्जाम को फोड़ के रहेंगे, आपको इस एग्जाम से पास होने से कोई ताकत नहीं रोक सकती, क्योंकि आपने इसके लिए बहुत लड़ा है, बहुत मेहनत करी है, दिन रात आपने एक करे हैं बेटा। सो दिस इज हाउ यू शुड गेट दिस एग्जाम, get over on the 12th of January 2025, right guys? So I wish again to all my lovely students बेटा, बस लगे रहो और बेटा 12 जनवरी को जब एग्जाम दे दो, इवनिंग के अंदर आई विल वेट फॉर योर रेस्पॉन्सेज। जस्ट राइट मी योर रेस्पॉन्सेज ऑन माई नंबर, ऑन माई व्हाट्सएप। आई विल बी very happy and the blessed once I will receive your messages guys. So we are always with you, अपने आप को अकेला नहीं समझना है। You are a very hard worker students, and 2025 onwards you are going to be a doctor for lifelong in India, in world. Nobody can remove this tag from you. You are a DR dot and your name from which year? From 2025. So I wish that you are going to rock in this exam. बस आ जाओ बेटा, पास हो जाओ और उसके बाद बल्ले बल्ले, राइट बेटा? So I hope that you are going to be pass this examination with lots of effort and definitely you are going to pass. You are going to pass and pass. मेरे को और कुछ नहीं पता है, आप बस पास होने वाले हो, ये मेरे को पता है। चाहे आपको पता होए या ना होए, लेकिन मेरे को पता है, क्योंकि एक बारी अरुण सर ने जो कह दिया उसको रोकना मुमकिन ही नहीं, नामुमकिन है। जितने भी बच्चे अभी मेरे को सुन रहे हैं, आप सब लोग बेटा पास हो, देख लेना, मजा आने वाला है 12th ऑफ जनवरी को, क्योंकि आपने बहुत अच्छे से जम के मेहनत करी है। और बच्चा आप चाहे कहीं से भी हो, वेदर यू स्टडीड इन द मिस्ट और नॉट इन द मिस्ट, डजंट मैटर फॉर दैट, बट you have to pass and you are going to be pass, right beta? So this is all from my side. Again, I wish you, to your family, to your loved ones, a very happy new year guys. May this year brings you a lot of happiness, lot of colorful condition in your life, in your houses, in your family, and you may pass this exam in this year. So again I wish you a very happy new year to all my lovely students guys. और फिजियोलॉजी तो अपन ने एकदम ऐसी बना डाली है कि बस अब तो अपने को मजा आने ही आने वाला है, राइट बेटा? So all my lovely students, very happy new year and enjoy your day, enjoy your new year and come with your flying colors. Thank you very much from my side. I am Dr. Arun Swami, your physio faculty from Team Mist. Again, wish you a very happy new year. Best of luck to all my lovely students.